Neuropsychiatry of SLE, a high-yield pocket guide for psychiatry residents. Systemic lupus erythematosus, or SLE, often manifests with significant neuropsychiatric symptoms. Understanding these is crucial for effective management in a psychiatric setting. First, let us look at the psychiatric syndromes defined by the American College of Rheumatology. Out of 19 total syndromes, the most common psychiatric manifestations include cognitive dysfunction, mood disorders, anxiety, psychosis, and acute confusional states. It is vital to determine if these are primary, meaning they are caused directly by lupus, or secondary, resulting from medications, infections, or metabolic imbalances. Next, we consider the pathophysiology. The mechanisms are complex but can be simplified into three main pathways. First, autoantibodies, such as anti-NR2 and antiphospholipid antibodies, directly affect the brain. Second, inflammatory cytokines cause systemic and local inflammation. Third, vascular injury, including vasculopathy and thrombosis, leads to ischemia. Together, these factors result in neuronal dysfunction and injury. When it comes to the diagnostic approach, remember that neuropsychiatric lupus is a diagnosis of exclusion. You must maintain a high index of suspicion, especially in young females presenting with first episode psychosis and systemic symptoms like fever, rash, or joint pain. The workup should include a detailed history, laboratory tests for ANA, anti-double-stranded DNA, and antiphospholipid antibodies, and neuroimaging like an MRI to rule out stroke or infection. In some cases, cerebrospinal fluid analysis and neuropsychological testing are necessary. Finally, management requires a multidisciplinary approach between rheumatology and psychiatry. Symptomatic psychiatric treatment involves the standard use of antipsychotics, mood stabilizers, or antidepressants. However, SLE-specific treatment is equally important and includes corticosteroids or immunosuppressants like cyclophosphamide and azathioprine for inflammation, or anticoagulants if thrombosis is suspected. A critical clinical pearl for residents is to carefully differentiate between steroid-induced psychosis and SLE-induced psychosis, as the treatments for each are fundamentally different. In summary, treat the underlying lupus activity to improve neuropsychiatric symptoms. Stay sharp, and always look beyond the surface symptoms.